Evet, benim saatim tamam Faruk'cum, sen hazırsan.
Evet, hazırız. Son 5.
Dear friends, colleagues, welcome to the second online webinar of the MasterClass of Reproduction series, which is organized by Turkish Society of Fertility Preservation. Turkish Society of Fertility Preservation was established with the aims to raise the awareness and educate healthcare professionals, patients, and public about the adverse effects of cancer therapies and surgeries on reproductive function on both females and males. Together with a very dear colleague of mine, Professor Sinan Özkavukçu, we will be hosting tonight a very important guest. Tonight's talk is entitled as Assisted Reproduction at the Times of Pandemic in Europe. What have we learned so far? It will be given by a renowned clinical embryologist, scientist, and former ESHRE chairwoman, Dr. Anna VEIGA. I always consider myself very lucky to know her in person, and I have no doubt that we will gain lots of important information and knowledge during her talk. Dear Anna, one more time, I would like to thank you very much for accepting our invitation and being with us today. I hereby pass the microphone to Dr. Özkavukçu to formally introduce our speaker.
Okay, thank you, Dr. Fındıklı, for this nice presentation. First of all, I would like to thank the organizing committee and the society for inviting me to moderate this beautiful webinar about a very hot subject. We will be talking about the COVID pandemic and its effects on assisted reproduction treatments and practice. We have a very distinguished guest this evening, Dr. Anna VEIGA. Hi, Anna. She is the director of Barcelona Stem Cell Bank at Center for Regenerative Medicine, and she is the member of ESHRE's working committee for COVID-19. So she will be presenting some very updated data about the subject, I guess. I'm privileged here to present Dr. VEIGA, even if we know her very well, and it is not necessary to introduce her. Before her speech, I would like to share her CV with you. Anna VEIGA took her bachelor's degree on biology at Universitat Autónoma de Barcelona. She completed her PhD in biology at the same university. She has been the research and development director of the biology area of the reproductive medicine service of Dexios Women Health and the director of Barcelona Stem Cell Bank since 2005. She holds associate professor title at Department of Health and Life Sciences, Universitat Pompeu Fabra since 2002. She served as the chairperson of ESHRE between 2011 and 2013. She has been the founder and coordinator of the MSc Master Course on Reproductive Biology and ART at Institut Universitari Dexios and Universitat Autónoma de Barcelona since 1998. She was the founder and long-term president of the Spanish Embryologist Society, ASEBIR, and worked as the IVF laboratory director at the Reproductive Medicine Service at Dexios Women's Health. Dr. VEIGA has published more than 350 scientific articles in national and international journals, 73 book chapters, and has more than 7,000 citations with an IH index of 42. She is in the review board of many high-quality scientific journals like Human Reproduction Update, Fertility and Sterility, RBM Online, Journal of Assisted Reproduction and Genetics, Stem Cells, Translational Medicine, and Zygote. She has many honorary memberships in scientific societies, and she is awarded by many governmental, scientific, and social institutions. So Anna, thank you very much being with us tonight. We are looking forward to having your talk. The screen is yours. Thank you.
Thank you. Thank you. I want to take the opportunity to thank the organizers, the Turkish Fertility Society, and my Turkish colleagues to invite me to deliver this talk. I have to say, first of all, that I'm not a COVID expert, not at all. I'm not a virologist, but because the chairmanship of ESRE considered that this was something that we needed to manage in a way or another, a working group was created, and I had the honor and the privilege to be named the coordinator of that group. And what I'm going to present this evening is more or less what we have done so far, what have been our guidance documents in the different times of the pandemic. Where are we now? What have we learned? We have had the possibility through all this year to learn a lot about COVID. I think that never before a pandemic was so deeply understood and analyzed and investigated. And I think that we have proved, we as scientists have proved that when we work and we work well and in collaboration, many things can arise, many good things can arise, and the vaccines are for one of the best examples of this hard work that has been done. The title is, as you see, Assisted Reproduction at the Times of the Pandemic in Europe, and what have we learned so far. The first thing, let me see, I wanted to introduce is the group, the working group, where we have been doing all the work that I will present. It's not an individual work, it's the work of a team. You see here the members of the group. They come from different countries. Some of them are clinicians, others are embryologists. We also have somebody who is representing the patients. We think it's very important that the patients get the correct information, and we have Satu Rautakalio as the president of Fertility Europe with us. And also we have the support of the ESRE Central Office. And in this case, we are extremely lucky to have Nathalie Vermeulen, who is doing a huge work with us. And thanks to her, I take the opportunity to thank her and all the members. You can find the information regarding all this in the ESRE website. There is a special section for COVID-19 working group. You see here on the slide how it looks like, and you can find all the documents there. You can also have the surveys, and you can also contact us if there is a need. The working group has focused mostly in doing different things such as to establish a guide practice in ART at these times, to support professionals and patients, and also to try to increase our knowledge on COVID-19, especially in what is related to reproduction, to assisted reproduction, but also reproduction in general. Moving towards the guide practice in ART. I will not go into detail a little bit. I will go phase by phase, but here you have the summary of what we have produced. We started by producing a statement in April 2020, and this was the phase 1 of the pandemic, and it was named the ESRE Guidance on Fertility Services During the Pandemic. We moved on and then produced another one because there was the need to try to see how we could restart the activity after the stop that was taken at the time of the heavy infections, and almost all services, all ART services stopped at that time. The third phase was to try to show how we could move on to safe ART services during the third phase of the COVID pandemic. We also work together with other scientific societies, and we produced a joint statement with the ASRM and the International Federation of Fertility Societies. This has been published in Human Reproduction Open. And also we have produced some articles, some papers related to what we have learned so far, and by using also the survey that we have performed to try to understand what was going on during those times. There's a paper in Human Reproduction. The first author is Luca Gennaroli, who belongs to the group. The Calm After the Storm, Restarting ART Treatments Safely in the Wake of COVID-19 Pandemic. More papers came out. One was authored by Nathalie Vermeulen and all of us, which showed how was the evolution of the activity in ART during the pandemic. And finally, we have produced a recommendation, a guidance document regarding COVID-19 vaccination and assisted reproduction. This was last January. The final document that I'm showing on the slide is a joint IFFS ESRE statement on COVID-19, who is almost more or less summarizing also what is our recommendation with regards to vaccination for pregnant women and for those that are considering pregnancy. And this was in the last month of February. To understand a little bit why we were producing the different guidance documents, it's important to see how the pandemic evolved. And this is something that we have seen in almost every European country. As I said, at the beginning of the pandemic, we produced our first document. The pandemic was just starting. At a certain moment, and this was during the month of March, when we were all aware that this was really something that never happened before, and that we had to take action into that by stopping the activity in ART centers, and this was done in the month of March. And in that case, our recommendation, the summary was that all fertility patients should avoid becoming pregnant at that time. Only a limited amount of activity could be conserved in ART centers. Then we produced some other recommendations, and this was an important one because we understood that ART centers were restarting their activity, and this was in April. We produced the ESRE advice for phase 2, recommending ART treatments. And then as it was again, as the pandemic was again restarting, we made the ESRE advice for phase 3, safe, how to work in safe conditions. And to finalize our statements, we produced an ESRE statement with regards to COVID-19 vaccination and assisted reproduction. Let's go into the detail of all that. You are all aware that at the time of phase 1, we said that ESRE advises that assisted reproduction treatments should not be started at the present time. This was in March 2020 for the following reasons. And these were the reasons why we wanted to make people stop their activity. First of all, to avoid complication from assisted reproduction treatment and pregnancy. The hospitals were full of patients affected by COVID, and it was not recommended that patients started the treatment because the hospitals could not handle these patients if they had any potential problem. Also, to avoid potential SARS-CoV-2 related complications during pregnancy, to mitigate the unknown risk of vertical transmission. I will go into more detail into that. We did not know exactly what was the effect of COVID with respect to the possibility that the fetus was also affected from the disease in patients that were pregnant and had the disease. to support the necessary reallocation of healthcare resources and to observe the current recommendations of social distancing. In cases, and this is important, especially for the society we are talking about, for fertility society, fertility preservation society, in cases of urgent fertility preservation in oncology patients, the cryopreservation of gametes, embryos, or tissue should still be considered. So we consider that as an urgent situation, and we recommended that all ART centers focused only on these urgent cases. At that time, for the patients that had started assisted reproduction treatment, we recommended that elective oocyte or embryo freezing for later embryo transfer should be done, and the policy of freeze all was recommended in our statement. What we tried to put in place was a kind of different maps showing how the activity was stopped, and at the 1st of March, almost all centers in Europe or in all countries were performing ART in the normal situation, except for Italy. As you know, Italy was the first country in Europe that really was affected by the pandemic with high number of cases. And as time went through, we saw that in the middle of March, other countries also stopped their activity in red in the map. In 1st of April, many more started to stop their centers, with countries that had only some centers performing the activity. And you see the progression of all of this. The reinitiation of the treatments was performed according to the different situation in different European countries. And we were trying to collect all this information to our through our Committee of National Representatives. This is a body in ESRE that tries to give information on the activity on ART anytime, on legislations, on different things that are quite different from one country to the other. And thanks to those people who collaborated with the working group, we knew at every time who was working and who was stopping the whole activity. Let's move to phase 2. In that phase 2, we were trying to put in place, we tried to put in place a triage questionnaire. Because the ART treatments were reinitiated, it was prudent to try to understand. And at that time, we have to say that in most countries, testing was not always available. So we needed to detect possible or potential positive patients to try to avoid the disease to spread into the population of the patients and also in the staff. So this questionnaire is both for staff and for patients. I'm not going to go into the detail. Almost all triage questionnaires for COVID have the same information. What are your symptoms? Have you traveled to special places where there was a big incidence of the pandemic? Have you been diagnosed? And also, have you had severe medical conditions like, I don't know, diabetes or respiratory disease that could also be of importance when trying to treat a patient with assisted reproduction at the times of this pandemic. With regards to the testing, after the triage was performed, we could categorize the patient and the staff in 3 different categories. The ones that have a negative triage, where we don't suspect any possibility. Or obviously, this is not 100% sure, because as you know, many patients that are affected or infected by COVID-19 are asymptomatic. So those are kind of patients that we will miss if we don't perform the tests. So in patients that have a negative triage, we include them in the ART treatment, and this is the scenario colored in green. In patients where we have a question mark, they have mild or non-specific symptoms. The triage is potentially positive, and in those cases, we perform a test. We recommend to perform a test with RT-PCR or with antigen to see if that patient in particular was positive or not. And if in the case the test was negative, we in principle get that couple into the program, but with some caution, taking into consideration that you can have false negatives when we perform the test, and also that patients can become infected in a later phase. In the case of a positive triage questionnaire in which you have specific symptoms or a previous COVID positive test, we really go to scenario number 3. In that case, we see if the tests are positive and we demonstrate that the patient has been infected by the virus, the patients cannot go into the program, so they have to be taken in care by the health care system to try to prevent complications. Also, apart from that, we recommended that obviously social distancing and sanitation, separate both pathways, and also the respect to triage rules has to be maintained. In different times of the treatment, such as the simulation and the monitoring, the lab, and also the fact that we recommended to use mini teams at that time, all this was the system or the strategy that we put in place to try not only to avoid the spreading of the virus, but also to work in perfectly safe conditions. During the simulation and the monitoring, minimal exposure has to be recommended, protection equipment, reducing unnecessary procedures. At the laboratory, we need to use dilution and safe disposals. No partners are allowed during the transfer or at that time. But I have to tell you that the methodology that we use in the lab in normal situations, not during COVID, but in normal situations, is a methodology that also prevents the spread of the virus. We dilute our samples, we wash oocytes, embryos, we use very tiny amounts of culture medium, and it's very difficult to try to imagine how a virus could get into those culture media, for example, even if an embryologist is infected, and could infect potentially our culture systems or even our embryos and other colleagues. The mini teams. This is something that we put in place, trying to say, if everybody is working at the same time, all staff is working at the same time, and somebody gets infected, there's the risk that nobody will be able to work anymore because all of them will have to go to quarantine. So we try to split the number or the personnel working in the lab in 2 or at least 2 or 3 different teams to try to avoid this possibility. At the time of just before oocyte retrieval, the triage has to be repeated, the test has to be performed, and the decision has to be taken if the patient is allowed to go on or not. With the freezing, the same thing happens as with other laboratory methodologies. And in fact, we have worked with HIV patients for a long time without any possibility of contamination, of intercontamination. And in this case, again, high security straws and vapor phase would avoid even the residual possibility that the virus could go from one sample to the other. These were the final recommendations, both for the staff and also for the patients. The thing is that the most important thing is take no risk, think of you and think of the others. Think about the risk, identify the symptoms, try to avoid contact in busy places or travel to areas of high risk, especially for the patients. And the safe circle, remain within a circle of known healthy family and friends. How to act? Our life during the pandemic has been very different. You are all aware of this. Obviously, the recommendations made by the health authorities are, as you perfectly know, wash hands and wear masks, expose yourself less, avoid crowds and contact with other people, inform others of your responsibilities, and inform the center if you are at risk or you are sick. The final recommendation, as I said, is take no risk. Maintain constant awareness that you must protect yourself and the others, and you need to also adapt to the new situation. If the prevalence of the virus decreases in your population, in the place where you live, you have to remain cautious. And if the prevalence increases, you have to become more strict with regards to what you can do. And this is a kind of code of conduct that we recommended at that time, not only for the patients, but also for the staff. This is phase 3. In that case, we were talking about the continuation of safe ART services. And in that case, we showed a kind of a colored grade of different situations. With relation to the number of cases reported in a specific place, country, or city or area, if less than 20 cases are reported per 100,000 people, the effect on ART, the impact on ART services is really with no cases reported, obvious is insignificant. Less than 20 is minor, and the more cases you detect in the population you are considering, the more adverse impact on ART services is observed. At the end of the story, we recommended to do the triage all the time, to do the tests if the tests were available. This is also something that was different between one country and the other. PCR was not something that was performed at that time regularly, but now I would say that the situation is completely different, and the testing of the patients is something that we need to perform to keep on the safe side. Moving on and going to the vaccination, I have to say that this was a document that took more time to be produced, because as you are perfectly aware, not only with vaccination, but especially with vaccination, the situation was changing from one week to the other. We had certain informations at one time, and 3 days later, the information changed, and we needed to change our recommendation. So at the end of the story, we were able to produce a statement on last January, on the 12th of January 2021. As I said, all these guidance documents are in the ESHRE website, and we made 3 questions with regards to that document that we were producing. In comparison with other societies in assisted reproduction, what we wanted is to deliver a very clear message. We did not want to produce a very long document with a lot of information. It's obvious that we get information on COVID more and more. People can get access to the articles that have been produced. Most of them are open. So we decided that what we wanted to do is to give a clear message to the patients, to the professionals, and to the public. So what we wanted to ask is, should men and women receive the COVID-19 vaccination before attempting conception? Should couples who receive COVID-19 vaccination postpone conception? And if so, for how long? And should pregnant women be vaccinated? Again, as more vaccines come and are available and are admitted for use and are authorized, especially by the European Medicines Agency, we made slight changes, but at the end, this is valuable for all kinds of vaccinations. The first question, should men and women need to get the COVID-19 vaccine or can get the COVID vaccine before attempting conception? At that time, and this is only at the end, 3 months ago, we said that ESHRE could not make recommendations on whether men and women attempting to conceive through assisted reproduction should receive the vaccine before starting the treatment. The first thing we wanted to say is that vaccination is encouraged when benefits outweigh possible risks. And this is always the case in all COVID pandemic. If the benefits outweigh the possible risk, vaccination has to be done. What are these cases? For example, in patients that have comorbidities and have a higher risk of COVID-19 and or pregnancy complications. And also when the high risk of COVID infection cannot be avoided. For example, when you are in a place where there is a very high prevalence, or for example, you need to go to work and you work with many other people and you cannot take the necessary precautions. Another thing that we wanted to stress was that access to care should not depend on vaccination status. As more vaccines are available, especially in developed countries, more and more people get access to the vaccines. But at the time of the initiation of vaccination, very few people were vaccinated, and it was considered that we could not say, no, you cannot be treated in an ART treatment because you have not received the vaccination. This was something that we wanted to prevent. And as I said, this was due to the fact, that vaccines were not available, and also to the fact that certain people, certain couples, or maybe women or men, decide to refrain from vaccination. And this is something that we have to take into consideration. We cannot prevent them to get into the treatment because of that. The second question. Should couples who receive COVID-19 vaccination postpone conception, and if so, for how long? And in here we have different viewpoints with regards to the need to postpone vaccination, to postpone conception after vaccination. Our recommendation was that it seems prudent to postpone the start of ART treatment, including everything, for at least a few days after the completion of vaccination, to allow time for the immune response to settle. If you have, for example, a heavy reaction to the vaccine and you are performing an ART treatment, you cannot distinguish between what could be a normal, I would say, other problem or a problem related to the ART treatment and the immune response to the vaccination that the couple or the woman has received. So we recommended to wait for at least a few days. But even we wanted to be even more cautious, and we said that in the absence of information on the effect of the COVID vaccine on oocytes and sperm, embryo implantation, and early stages of pregnancy, and to allow time for antibody development, a more cautious approach could be considered, which was to postpone the start of the ART treatment up for 2 months. This was received not only very well by professionals and even by the patients who said, I'm not going to wait for 2 months. after my vaccination, because I don't want to delay the start of my treatment. In any case, it's obvious that vaccination clinical trials, or vaccine clinical trials, most of the times avoid using pregnant women to see if the vaccine has any effect. So there were no data with respect to the effect of the COVID vaccine, not only on pregnant women, but also there are so many unknowns on what can be the effect of an immune response in the different phases of the AR2 treatment. What we highlighted is that treatments should not be started in women who had a significant side effects from COVID-19 vaccination, and a prudent waiting period would be recommended in those cases. With regards to the pregnant women, again, let me repeat that we did not have any data. Clinical trials that were performed to try to assess the safety of the vaccine avoid using pregnant women as volunteers, and as such, we did not have any information on what could be the consequences of that vaccine during pregnancy. We said that the decision on whether to use the vaccine in pregnant women should be made in close consultation with a healthcare professional after considering the individual benefits and risks. Again, if the benefits outweigh the risks, vaccination should be given. But pregnant women should be informed at that time about the lack of long-term human studies on COVID-19 vaccination, and we recommended that the pharmaceutical companies give us the possibility to get this information by having volunteers in their clinical trials. And this is something that is moving on, and we are having more and more results now that reaffirm the fact that it doesn't seem that the COVID vaccine can be detrimental for pregnant women. Why did we recommend at the time, at the initial phases of the pandemic, to avoid people to get pregnant? Look at this data, and this data is from a study performed in the United Kingdom, you see here. And we saw during the pandemic period, the number of stillbirths per 1,000 births. It was 2.38. We saw that, and those authors saw that at the time of the pandemic, with a limited number of cases, obviously, but in any case, significant enough because the comparison was more or less the same, this number increased a lot. So there were many more stillbirths, and the difference was significant. So stillbirth rates increased during the COVID-19 period. Another thing that we needed to take into consideration is that pregnant women are affected or get a much more severe disease than the women that are not pregnant. They get a worse prognosis, they go more to the hospital, they go more to the intensive care units, and at that time we considered that we should try to avoid the possibility of having those pregnant women affected from the disease. The same thing happens in those numbers, and this is something that comes from Italy. During gestation categories during the lockdown, March, April, and May, and the same period in 2019, they compared that. So with a high number of pregnancies, and again, the percentage of stillbirths in 2019 was 1.07, while it was 3 times more significant during the time of the pandemic. So again, let's be careful with pregnant women and the disease and COVID-19. The most important question is if a woman is pregnant and gets the infection, is she going to transmit the disease to the fetus? And you have here two articles that were produced by different consortiums, and in this case, it's a kind of case report in which it was demonstrated that there was a transplacental transmission of the SARS-CoV-2 infection. And in this case, this was confirmed by comprehensive virological and pathological investigations. They saw in that case, in that paper, that with a very strict and comprehensive analysis of the symptoms and the serological status of the woman and of the child, the neonate presented with neurological manifestations similar to those described in adult patients. Here, another paper in the same journal, in Nature Communications, and this analysis showed that the data that the authors provided support the hypothesis that in utero SARS-CoV-2 vertical transmission, while low, is possible. So this is something that we need to take into consideration. There is a review about the vertical transmission of coronavirus disease 2019. This is a systematic review and meta-analysis, and again, with sufficient numbers, because they collected a lot of information, they saw that there is evidence of SARS-CoV-2 vertical transmission when the infection occurs in the third trimester of pregnancy. Most of the cases are in the third trimester of pregnancy. You see the numbers. At the end, only a very limited number of cases were positive in the case of the newborn. And in some cases, it could not be demonstrated that the virus was transmitted through a placenta. Maybe if the child was analyzed or was tested 20 hours after that, it could be that the contact with the mother at the time of the delivery could be what produced the infection in the child. But in any case, it seems that vertical transmission is possible, even if it's very low. Let's see scientific data that I think are very important. Do we know if the embryos are permissive to SARS-CoV-2 entry? It is important, and this has been studied from the very beginning of the pandemic, to understand that the virus gets into the cells through two different ways, through our receptors, the AC2 receptor, and to this protease. And in that work from the group of Manuel Viotti, who in fact is trying to get more data on this and has obtained, has won the award that we put in place for COVID. ESRE has a research award that is put in place every 2 years for research activities, for projects related to different topics. And this year we considered that we had to fund projects related to COVID. And in fact, this person, Manuel Viotti, is the one that has gained the possibility to work in his project, which is trying to understand if the human embryo if it's possible that the human embryo gets infected by the virus. And these are his preliminary results. This has not yet been published in a peer-reviewed journal. As you can see, is in bioarXiv, which is a preprint server for biology. And he showed that exposure of blastocysts to fluorescent reported variant serotype with the virus revealed that it is dependent on ACE, and entry is possible and fusion of the virus is possible. There are different things that could be discussed in that work, especially the concentration of virus that was of virus that were put in contact with the embryos. But in any case, this work is still going on, and we expect to have results published in the near future. What else? What about the sperm? Also, a huge amount of papers are being, well, not huge, but more and more papers are being produced with regards to the effect of the virus on spermatogenesis. And it seems that when a man is affected of COVID-19, there are consequences on spermatogenesis. Those men, even the numbers are low, have oligozoospermia, and they have a significant increase in leukocytes in sperm. It needs to be understood, fully understood, if these effects are produced by the infection itself, I mean, on the general health status of that man, or if it has a specific effect on the testicle. It seems that spermatogenesis is impaired, but it seems true that these men recover and get back to a normal spermatogenesis once the infection is over. My take-home messages. Our summary from what we have been doing all this year is that all countries are now have now returned in providing services after May 2020. All countries continued emergency oncology cryopreservation services. Our guidelines were used by many countries, especially in the ones where the competent authorities did not provide any specific recommendation. ART COVID-free clinics are possible through triage and testing. Each ART service should implement the routine advice as well as a code of practice that I described for patients and for staff, avoiding the risk from the start of the activity. We need to use measurable and easy available parameters that permit objective adaptation and risk mitigation. We need to notify the cases to, in that case, the European Center for Disease Control. Men and women should receive the COVID-19 before attempting conception when available and when benefits outweigh risks. Postponing ART treatments should be considered for at least few days after complete vaccination, and we still recommend this. Pregnant women should be vaccinated again when individual risks outweigh, individual benefits outweigh risks. There is not a question mark, but we need to take into consideration that pregnant women who have the disease late in pregnancy, in the third trimester of the pregnancy, have a limited risk of vertical transmission, and this needs to be given as an information. And adaptation to changes scenarios is needed during this pandemic, and we need to change our recommendation whenever there is new information that is coming. And I think this is the big lesson of what we have learned from COVID. Science is useful, has proved to be extremely useful during this pandemic. Scientists can provide emergency actions at this time, but again, we have to be ready to change our minds if there's a need and if we get new information. And we do not have to say, no, listen, I have said that, and this is something that I will maintain forever. No, maybe we need to change our minds for certain things as more information is available. Let me give my last slide by telling you that we have a webinar. We have a webinar planned for the 12th of May, organized by ESRE, SARS-CoV-2 and assisted reproduction in 2021. We will talk, and we have experts. You see the names of the speakers, people from the European Center for Disease Prevention and Control, Ashley Moffat, who is from the University of Cambridge, who has produced a lot of work with regards to infections in pregnancy, and especially during COVID and the vertical transmission. We have the patients, somebody from Fertility Europe, a patient that will give her experience, and somebody from our working group, in that case, Edgar Mocano. And you see here the topics that they will treat. And I invite all the ones that are interested in following with this to participate in that webinar. The registry is free of charge, and as we have a limited number of participants, we encourage you to register as soon as possible to have your place during that seminar. This is all I wanted to say. I will be happy to reply to questions if I can. Again, I'm not a virologist, so don't ask me difficult questions, because I will not be able to reply. Thank you very much for your attention.
Thank you very much, Anna, for this beautiful talk, for clear recommendations and registrations and robust messages for us. Nejati, if you let me, I have one or two questions for her.
Yeah, sure. Yeah.
Okay, before we go through the questions from the audience. Anna, I would like to ask these stillbirths from Italy and United Kingdom. Did they follow the cases that those stillbirths were just because of the infection, or just a sporadic thing? And you know, the infection can be asymptomatical, so you don't know if you had the COVID-19 or something, but you have the antibody in your serum. So did they make any follow about those cases?
Yes, I could not put all the information I had in my hands, but we are trying to put in place, and we have put in place, in fact, a survey to try to collect all the data with regards to pregnant women after ART that had COVID. And we tried to collect all this information. These are not the papers that I showed. In those cases, probably the disease was, and the health status of the woman was in fact what produced the death of the baby. But this is something that is also appearing in our data. There are more stillbirths and there are more miscarriages. We are working on that. We have collected more or less 50 pregnancies, and we are working on the data to try to collect more information to really give the correct message, not only to professionals, but also to patients, to see if really this infection is causing something during the pregnancy, especially in the initial phases of the pregnancy. Most of the data correspond to the third trimester, but probably it's completely different if you get the infection initially or you get it later on. So I still don't have the data. We are working on that. And again, through the Committee of National Representatives and through all our members, because this is also on the website, trying to attract all this information to see really if there is a connection between these miscarriages, these stillbirths, and the fact that these women were affected from the COVID, and what can be the mechanism. I cannot give you an answer because
I see, because the results are very significant and we can follow up those patients. It is not hard, so we can get an answer. Thank you. And the other question is, Do you have a question of whether the patient had vaccination or not in your questionnaire, in the questionnaire of the ESHRE? I may missed it, but
No,
yeah.
because at that time vaccines were not.
Yeah, but we have to implement this one also to our
Exactly, we have to adapt to the new situation, and we have to really have this in our questionnaire, in our triage questionnaire. As I said, this is evolving. This is evolving.
Sure.
As days go by and weeks go by. So we will have in a few months' time most our patients vaccinated. So the triage will not be necessary anymore, and probably and the tests will not be needed anymore, probably, because if they are immunized, I mean, there's no need to do that. So we need to adapt constantly to the new situation.
Can I add something on it? Anna, we know that the Nordic countries have excellent registries.
Yes.
And it's been like more than a year now. And even for the spontaneous pregnancies, do you think that they are helpful or not?
There are more and more data on spontaneous pregnancies. And in fact, we do not expect that ART pregnancies are very different from the spontaneous pregnancies.
Yeah.
But consider that the age of our patients is a little bit different from the age of spontaneous pregnancies. We have many women with a more advanced age than the ones that correspond to spontaneous pregnancies. With regards to the registries, yes, the Swedish and the Scandinavian countries have fantastic registries. I haven't seen any special publication on that, because at the end you need to put into relationship the registries they have for ART and the registries that they have for general health. Probably these papers will come out at a certain time, because they will do that. Yes, we will get this information. The ones that do a proper job, at the end they get the information.
Get the reward.
Yeah.
Okay, thank you.
Necati, do you have a question, or shall we?
Yeah, you can continue. Yeah,
I'm going to proceed through the questions from the audiences.
Yeah.
All right. The first question here I can see says that since one of the common symptoms is high fever, and high fever severely affects sperm production, do you have any recommendations for men recovered from COVID-19?
Not really, but from what I have read is that once the guy recovers from the disease, it seems that spermatogenesis goes into normal. As we know that spermatogenesis takes long. We need to take into consideration when the man was affected from COVID, and then the start of the ART treatment. Yeah.
There were several publications about the severe testicular damage.
Yes.
Yeah.
But these were severe cases. And I think that we need to separate the situation between the effects direct to the organ in that case testicle, and the effects produced by the general deterioration of that person and the inflammatory problem that
you mean a dissemination can also affect testicles also, I mean, exactly. a global infection. So yeah, but the single disease on the testicles is not, I mean, obvious, right? It's not seen.
Exactly. And the thing is that it doesn't seem that the virus is present in the sperm, and it doesn't seem that COVID-19 is a sexually transmitted disease. Okay.
Mm-hmm. Yeah. Okay. So the other question is, your message regarding vaccination is very clear. For women just recovered from COVID-19, should we also advise them to wait for several days to start the treatment?
I would say that the general health condition of that woman needs to be taken into account. If she suffered from a very, I would say, mild disease, and she's doing well, and I mean, she can wait for a few days, but at the end, it will depend on her general health condition at the end. You don't want to be treated by ART when you don't feel well. I mean, and I understand that many women, and this was a criticism that we had when we recommended to stop. I understand. I've been working in ART for more than 40 years now. I know how anxious women and couples get to get pregnant. But let's understand that 2-3 months is not the end of the world. I mean, you can wait for 2-3 months. For example, if the situation in your country is terrible and the hospitals are full and people are dying, I mean,
yeah,
these couples need to understand that it's not only for the rest of the population, it's also for them that they need to keep calm and to try to. We have never been in a situation like this one, never. So yeah. Let's try to be careful with this. And also, I mean, when the pandemic was at its highest levels, I was thinking, can you imagine having to go now to the clinics to get injections, to get oocyte retrieval? I mean, we were not in that kind of mood, I would say. And I think that we need to make at that time, and we made an effort. And I think that most of the patients understood perfectly that the situation was so terrible that they needed to wait.
Yeah. The other question is also about testicular tissue. We almost answered these questions, but there is an addition saying that could this testicular damage come from a disturbed immune response, or I would add a cytokine discharge? Do we have any
solid evidence?
Evidence about these kind of immune responses?
It can come from different actions or from different things that have happened during the COVID disease. There is more and more information that is available. In fact, this is during the annual meeting of ESRE, next annual meeting, who will be unfortunately a virtual annual meeting again. There is one session regarding the effects of COVID-19 on male reproductive function. This will be a review made. The speaker will be Alan Passy from the UK, and he will probably collect all the information that is available at this time. This will happen end of June, and we will have the possibility to hear all the information that has been collected with regards to the effects of COVID-19 on sperm function. But I think that most of the papers show that even if there are effects, these effects go over once the disease is over.
Okay, good. Another question is about PCR tests. the question says that should we ask a negative PCR test to accept the patient right now, because the asker says that the studies indicate that infectivity may be limited for the virus. Should we have this negative PCR test to have this oocyte pickup, for example? Or let me ask this, for different procedures like collecting semen, shall we ask a PCR test?
I don't think that we need to ask for a PCR test before collecting semen, especially if the triage is negative.
Okay.
In most ART centers, they still get a PCR test before oocyte pickup, or a few hours or 24 hours before oocyte pickup, and in some cases also before transfer. I would say that if the pandemic is going down in that specific country, for example, and we have less infections and more people are vaccinated, probably we will have to change our policies. Mm-hmm. And this was what I was saying during my talk. We need to adapt to the new situations. And this is evolving. What was true a number of months ago will not probably the case in the coming weeks. So imagine that you get a patient that comes and says, I have received my second dose of the vaccination 3 weeks ago. Why? To perform a PCR. Okay. Mm-hmm. Why? I mean, but you need to adapt to the different situation. Or if imagine that you are in a country or in a city where the number of cases is really, really very, very low. Maybe you can avoid having a PCR test in those cases. Okay. You need to
adapt, right?
Adapt to the different situations as we move on.
Mm-hmm. Okay. As you stated in your talk, pregnancy itself seems to be a high-risk situation. Why are you hesitant about encouraging patients to be vaccinated? Because, the high risk must be vaccinated, but not pregnant.
This is a very good question. Again, if the benefits outweigh the risk, they should be vaccinated. That's for sure. But again, we did not have any data. We did not have any data. We did not know how pregnant women reacted to the vaccination. Why not? Because the pharmaceutical companies did not include pregnant women in the clinical trials. So this was why we were so prudent. So, but again, if you have a woman who is a very high risk because she works, I don't know where, or she is in a city where the prevalence of the infection is really high, or if she has a comorbidity that, then yeah. Go ahead, go with the vaccination. And now we have more and more data of pregnant women that have been vaccinated and they are perfectly healthy and no problem has arisen.
Yeah, but also it is not very easy for a pharmaceutical company to include pregnant women to phase studies, right?
Very risky.
Yeah. Nejati, you would like to say something?
Maybe we should have the data from Israel. You know?
Yes. We should have data from people that have achieved a very high percentage of immunized people because they have been vaccinated. Yeah. And then, but again, with this virus, we are collecting data as we move on. The same thing that happened with the thromboembolic problems that came out. What do we know? We know more things now than we used to know, but we did not know that this was going to happen. We did not know. We had no idea. So we get information and then we said, okay, I don't know if this has happened in your country, but in Spain, I have to tell you that with the AstraZeneca vaccine, we went crazy. We went crazy. They said, you have to vaccinate people from 60 to 65. Then the day after, no, from 65 to 70. The day after, no. Don't vaccinate the young ones. Then, but at the same time, they were vaccinating those people. And those people were completely scared because they received the vaccine, and the day after, there was news in the newspaper saying, no, people of that age should not be vaccinated.
Nocebo effect, huh?
Exactly. So at the end, you see that we are learning. Yeah. But we also have to learn how to communicate these things to the population. And now I would say that never before such a big amount of information regarding scientific things has been transmitted to the population. Now, I don't know, but here you go to the street and you find 3 virologists, 1 epidemiologist. I mean, everybody is an expert and everybody can give opinions. I mean, we need also to try to provide information, clear information. Let's be cautious and let's not change the kind of information we provide because people are not able to digest all this, and we create confusion.
Yeah. Well, the last question is, what do you think early pregnancy loss in pandemic? I mean, why do you think it is the cause of the early pregnancy loss specifically?
I don't know.
Maybe thromboembolic problems because it is high in
inflammation. What do we know about implantation in, I don't know, maybe an asymptomatic woman, but who has some effects of the virus, even if she is not showing any symptoms? We don't know. The more we move on, the more things we will know. And as I said, this research grant that was promoted is something that was really necessary, and we are proud to say that we are the only assisted reproduction scientific society that has dedicated funds to try to understand things that we don't know or that we cannot understand right now.
Yeah.
Well, thank you.
Thank you very much, Anna, being with us.
Yeah, it was an excellent presentation, excellent discussion.
Nice.
And thank you so much.
Yeah,
it was very fun and good.
It was my pleasure. It was my pleasure. And again, it's not my individual work. It's the work of a group, a working group. I have to say that has dedicated a lot of time and energy. And I'm privileged to have them with me, and I'm proud of the group and of what we have been able to produce in such a situation.
Yeah, thank you very much for being with us.
Let's see the results in coming weeks or months. Yeah. Okay.
Exactly. Yeah. We will have to follow up at the end.
Yeah, definitely. Again, thank you very much, Anna, for being with us today.
Thank you.
Okay.
Bye-bye.
Bye-bye.
Bye.